Thank you, Hugo, for the very nice and warm introduction. Thanks for organizing and for having us here. So I'm going to present some data on the feasibility and acceptability of digital monitoring systems in psychiatric disorders, systems that we actually set up here in Münster, and my colleague Tim Hahn will later present some examples of how we can actually analyze these data. So as all of you will know, we are facing a problem in our classic psychiatric studies. We're usually conducting baseline and follow-up assessments, but we are missing what is happening in between. More precisely, we are missing a lot of details on what is actually happening during the treatment process. So what is happening while the patient is at our hospital undergoing intense treatments? We don't know how the systems are changing over time. So one thing that we would actually want to have is kind of a inpatient monitoring or a treatment monitoring system, which actually allows us to gain standardized assessments of symptoms and also information on the interventions. Second of all, we would also like to know what is happening after the patient is discharged. So maybe the patient will be relieved from depression, will be discharged, and we would like to know how symptoms and behavior will actually change and evolve over time during his day-to-day life. And we have implemented systems to address these challenges, and I will try to explain how we try to tackle this and how the acceptability of these solutions are from our observations. So regarding the treatment monitoring system, we implemented an extension of our EHR system at our department for psychiatry, which comprises digital assessments based on tablet computers. So basically every patient with an affective disorder or a psychotic disorder that is presenting at our hospital will be asked to complete a digital assessment by using a tablet computer. This comprises risk and symptom profiles, and importantly, all of these data is then automatically transferred into the EHR system and accessible for the treating clinician. And second of all, we have implemented an informatics infrastructure for the data transfer between the EHR system and research databases. This allows us to actually export and store relevant information from the EHR system, including details on the medication, on the diagnosis, laboratory assessments, parameters of electroconvulsive therapy. So basically information that is reflecting what is happening during the treatment process. And of course, we can then merge this information with our risk and symptom profiles and also with further research data. How are these methods actually accepted by the patient? So during the first year when we started and implemented this system, we approached 364 affective disorder patients, and approximately 67% of them actually were willing to participate in this effort and completed the digital assessments. I should also say digital assessments were conducted at admission, during the treatment, every 2 weeks, and at discharge. So when you see this number, 67%, and when you evaluate this number, please keep in mind that the patients were approached by research staff. So what I want to say is that I think once this is actually implemented in clinical care and once the clinical team is approaching the patient, I would assume that this number would go up even higher. Also, we observed that 90% of all participants did not require any additional support during the data entry. And I think this is a pretty promising result because it actually shows that these patients are, that it's a feasible method and that the patients are actually able to engage in these kind of efforts. And you might think that it's an easy thing actually to fill out these kind of assessments with a tablet computer, but please keep in mind, these are inpatients, psychiatric inpatients that are really severely depressed. Also, we could see that psychiatric symptom load did not interfere with these assessments. And only 4 of these participants dropped out of the study prematurely, also pretty promising finding. And 70% of all of our clinical staff, including nurses, doctors, auxiliary staff, actually worked with the information that we gathered based on these tablet computers. Also showing that actually this is very well received, and a lot of our clinical colleagues are actually using this kind of information right now. We had one specific question that was of interest for us. We actually wanted to compare or wanted to investigate if we would see any differences in the acceptability of these digital methods in psychotic disorder compared to affective disorders, because there are still a lot of reservations and a lot of clinical colleagues regarding the application of such digital monitoring systems in psychotic disorder patients. However, we did not see any differences. Psychotic disorder patients basically showed the same inclusion rates, dropout rates, and also very high satisfaction with the digital assessments. Overall, all participants, psychotic disorder and affective disorder patients, showed 98%, so really high subjective satisfaction with the digital assessments. One thing that I want to note, however, is that psychotic disorder patients needed more support with the tablet handling and a little bit more time. So to sum up, it appears that both in psychotic disorders and affective disorders, this kind of digital monitoring system is really well received and there's high acceptability, but keep in mind that psychotic disorder patients will probably need a bit more support and more time. So then I would like to move away and go to the second part of my talk, which is the outpatient monitoring system. And for this purpose, Tim and me introduced an application, a smartphone application called Remap, which stands for Remote Monitoring Application in Psychiatry. This app is now available for Android and iOS. You can actually download it if you want to have a look at it. And what do we actually collect with this app? So you have already heard about active data. We are actually collecting active data, namely the back depression inventory. We ask all participants to fill out the back depression inventory every 2 weeks. And we are also assessing mood based on single items. So we ask the patient every 3 days, how is your mood today? And ask the patient to rate this on a scale from 1 to 10. We collect data on the hours that the patient sleeps, and we collect voice samples. So we ask the patient every week to report in up to 3 minutes on his well-being during the last week. And of course, we are complementing this with passive data that we retrieve from Apple Health Kit and the Google Fit on the device. This covers, of course, distance, steps, acceleration, and geolocation. First of all, when we started this project, we asked ourselves how valid the mood assessments actually were that we were collecting. And to answer this question, we compared the smartphone mood assessments with classic paper pencil assessments that we conducted at the time of recruitment. So basically we did both. We did paper pencil assessments and we assessed mood via the smartphone. And what you can see here is a very high correlation between the non-smartphone and the smartphone ratings. You can see that for the back depression inventory, we have an intra-class correlation coefficient of over 0.9, so very high correlation. And we also see a very high correlation with depression ratings from external research raters based on the Hamilton rating score. So we really see that these data that we actually collect via the smartphone appear to be highly valid compared to the standard assessments that we use in clinical and research routine. The second question that we were asking is how the adherence retention in our app was. So actually, how would patients use the app? How well would this be tolerated? Up to now, the app has been distributed in roughly 1,000 participants, and the median duration was 135 days, which is actually, I think, kind of a really nice period of time, which gives us a lot of information during a quite a long period of time. You have, however, you have to know, however, that our study design included a minimum study duration of 2 weeks. So basically, when we asked the patients to install the app, we asked them to send us data and to let the app installed for at least 2 weeks. And after these 2 weeks, they would receive a financial compensation. And as you can see, more than 90% of our participants actually did that and sent us data and used the app for the 2-week period. And then we told the patients, okay, you can continue and use the app for more months or more weeks to come. And if you would send us data for at least 1 year, you would receive another part of the financial compensation. And also, not really surprisingly, you can see that the retention rate is going down and that after 1 year, only 1/3 of patients are still sending data. I'm saying only 1/3 of our patients. On the other hand, please keep in mind, we didn't contact these patients at all during this 1 year period. Here you can see that we actually collected data from very different subgroups: healthy controls, major depressive disorder patients, bipolar disorder, anxiety disorders, and psychosis. And actually, you can see that across all these groups, participants were sending active and passive data in the same amount, which is also, I think, encouraging because it shows us that this app is working in all these diagnostic categories. We also investigated if retention and app usage would be moderated by factors such as age, sex, and diagnosis. As you can see here, descriptively, female participants had a slightly higher duration of the app usage, but this was not a significant substantial difference. And also we did not observe any substantial difference in the duration between the diagnostic groups. Also, one thing that I want to note is that older participants actually sent us data for slightly longer periods of time. So higher age was actually associated with longer app duration. Last of all, we then tried to figure out if several potentially relevant baseline characteristics, including IQ, hospitalization, global level of functioning, and the depression severity at baseline would actually be able to predict participation or the retention rates. And to that end, we trained a multivariate classifier, a random forest classifier based on these features. And we actually observed that this model was not able to make any prediction on the participation, retention, or retention rates. So what that actually means is that these baseline features do not appear to influence or bias participation or retention rates in a substantial manner. Again, I think this is kind of important thing to know, that the app usage does not depend on these factors in a substantial manner. Yeah, and with this, I'm already at the end of my talk. I hope that I have made up some time and that I am able to leave some time to Tim, who will probably present some examples of what we can actually do with the data that we collected with these systems. Thanks a lot for giving me the opportunity to present this data here. It was real fun. Thanks, Hugo, and looking forward to discussion.